Want to finish early? No problem. We'll take some questions for 5 minutes or 10
Now
minutes.
you can share the screen, Sam. So, good evening, everyone. We are restarting our BOA PG lecture series. This is the fourth season, and we are coming back to the lectures by the speakers, followed by the open discussion by the speaker and the students attending. This is mainly basically for all the PGs. And today, to start with, we are starting with the most basic topic with which we start our ophthalmology is the refraction. And to start with the refraction, we have our speaker, Dr. Zain Khatib. He has been a good friend, and like we can say that we are neighbors since childhood. And he practices just at the Baikala, and he has a very keen interest in PG teaching. So we'll be starting with his refraction basics. If at all we are not able to finish the lecture today because refraction is a vast topic, we will continue the second lecture in the upcoming series. Over to you, Zain.
Thank you, Dr. Sumit, for the warm introduction. And I would like to thank BOA for giving me this opportunity to teach something that is really close to me, that is refraction. And it has a lot of optics and a lot of conceptual learning. So it's a very vast topic. The discussion on refraction can go on for a long time, but what I aim to teach over here is basically what you don't find in textbooks. So I hope that most of the students have read refraction at least once, so that we can discuss the optics at a deeper level, and we can always answer questions at the end. So without wasting much time, let me go ahead. So refraction in terms of optics is the science and art of prescribing glasses. And truly it is not only a science, it's an art, because there's so much you need to know. And it is an absolutely essential practice to learn and master, especially during the residency days. Because after that, if you haven't learned in residency, you're not going to do it later with the new machines coming up. So to classify refraction, it is broadly classified into objective and subjective refraction. And what are each of these? So objective refraction is the step one of the refraction, where we use manual or automatic methods to deduce the refractive power of the patient's eye without using the assistance of the patient. So the manual method of doing objective refraction, as we all know, is called as retinoscopy. And the automatic method of doing the same is the autorefractometer. So after we deduce the refraction through objective methods, we get this kind of a prescription, which we have to learn to get with the help of objective refraction, where all my prescriptions will be written like this. And this is the common form. There's a sphere notation, -1 diopter sphere with a -0.5 diopter cylinder and the axis of the cylinder at 90 degrees. Now, once we have got this with the help of the objective refraction, we do the step two, which is the subjective refraction, where we use the patient's assistance and help to refine this objective prescription. Okay, so gives us the exact power that the patient will need, and from this we can get the final prescription of glasses. So this is what refraction broadly is. Objective refraction is divided into retinoscopy and the autorefractometer. Autorefractometer I'm not going to discuss, because autorefractometer just involves making the patient sit, the machine does everything, and you get the ready-made prescription at the end. What I'm going to discuss is retinoscopy, and in retinoscopy there are certain topics. We'll start off with the principle and optics of retinoscopy. We'll move on to understanding what is dry and wet retinoscopy, and then we'll understand the procedure of how we can get the prescription from retinoscopy. So again, I'm not going to discuss the different types of the retinoscope. You can read that, it will be there in the textbooks. The streak retinoscope is the most commonly used one these days, and I'm sure if you're a resident, you must be having a streak retinoscope, where a streak of light is projected into the eye and it can be rotated in all directions for different axes. So all my retinoscopy diagrams will be with respect to the streak retinoscope. So what can we expect to learn with respect to retinoscopy from this presentation? Before we start retinoscopy, we need to understand the optics of ametropia, that is myopia, hypermetropia. Then we'll go on to understanding the principle of retinoscopy, and very important, why the pupil reflex moves in retinoscopy. Then we'll understand the working distance concept, the effect of cycloplegics, getting the refractive error, and finally about astigmatism. Okay, so all my diagrams will be somewhat like this. The ray diagrams that I'm going to draw, where you can see that this is the patient's eye, and a optical plane will be passing through the part of the patient's eye from which the refraction is supposed to take place, that is somewhere near the crystalline lens, and perpendicular to this optical plane through the center of the eye passes the principal plane, and the intersection of these two is the nodal point of the eye. Okay, the thing about the nodal point is that the rays pass undeviated through the nodal point, coming inside and going out of the eye. So before understanding retinoscopy, we need to understand the optics of ametropia, and for that, to define the characteristic of any particular eye, it is defined with accommodation being at rest. What happens when parallel rays enter the eye? Where do they focus? Do they focus on the retina, in front or behind? And the second rays which come from the retina, where do these points converge, or where do they focus? And the point where the rays coming from the retina, the point where they focus, that is the far point of the eye. So understanding the far point is very important. So let's understand the basic emetropia, where there's no refractive error with the accommodation being at rest. Parallel rays entering, they focus on the retina, and the rays which come out from the retina, they are parallel. So because of this, the entering rays and exiting rays are the same, and because the rays coming out from the retina are parallel, the far point of a emetropic eye is infinity, or for all practical purposes, it is 6 meters, which is the closest distance at which the rays appear to coming parallel. Now, it is not only important to understand the rays coming from the central part of the retina, but also rays coming from a paracentral retinal point, shown A over here. This will help. Yeah.
Sometimes your slides are getting blurry in between, so I request you to close the video so that the streaming is more smoother. Your voice quality is good, but sometimes the slide becomes slightly hazy in between. So you can shut down your video and continue. Yeah, better.
Okay. Okay. Yeah, so I'll continue. So now the rays coming from a paraxial retinal point, we do a two-ray diagram to understand these rays. Okay. So the first ray comes from that paraxial retinal point, passing through the nodal point undeviated. And the second ray is parallel to the principal axis, undergoes refraction at the optical plane, and then comes out. So this is another way of showing how rays coming out from the retina, how do they come out? So in an emetropic eye, they come out parallel. And this sort of diagram is very important for understanding retinoscopy, as I'll show you later. So this is about emetropia. Coming to hypermetropia, the parallel rays which enter the retina with accommodation being at rest, they focus behind the retina. And the rays coming out from the retina, they are divergent. So if we continue these divergent rays, they converge at a point behind the patient's eye. So the far point in hypermetropia is behind the patient's eye. Coming to the paraxial retinal point diagram. So the first ray passes undeviated through the nodal point, and second one comes out divergent, and we see the far point behind. Similarly, for myopia, the rays that come into the eye, they focus in front of the retina, and the rays coming out from the retina, they are convergent rays. So the far point of a myopic patient is in front of the patient's eye. Again, the two-ray diagram is somewhat like this. Okay, so for myopia, one very important thing to understand is that the far point of myopia, the distance, we can actually measure the distance. It is the reciprocal of the dioptric power of the myopia. So depending on what is the dioptric power of the myopia, we can estimate what is the far point. So for example, if the myopia is minus 0.5 diopters, the reciprocal of 0.5 is 2 meters. So the rays will focus at 2 meters. Similarly, if the myopia is minus 1.5 diopters, the rays will focus at 67 centimeters, or the far point of minus 1.5 is 67 centimeters. Similarly, minus 3 diopters, the far point is 33 centimeters. Okay, so with this basic understanding, we can go on to the optics of retinoscopy. Now, very important is, what is the optical principle of retinoscopy? Okay, and this is something that you must know at the tip of your tongue. So the optical principle is that when an area of the fundus is illuminated, by light coming from the retinoscope, the illuminated fundus reflects back into the pupillary area to form a pupillary reflex. And when the retinoscope light source is moved across the eye, the behavior and motion of this pupillary reflex will depend upon the refractive status of the eye. Okay, so this is what is important. When you move the light source in front of the patient's eye, the behavior of that pupil reflex, how it moves, in what direction it moves, that will depend upon the refractive status of the eye, and that is how we can understand the refractive status. So just a quick way to show you this. Okay, so here we can see the retinoscope is being moved in one direction and the pupil reflex is moving in the opposite direction. So this is called as a against motion. Okay, in this second example, you can
He's disconnected, I suppose.
Yeah, we'll wait for him to rejoin.
Yeah.
I request all the students who have joined, try to share this with your colleagues. We want more and more PGs to attend. Last session, we had about 125 PGs attending. Also, I take this opportunity to request all of you to fill up the BOA membership forms and become a member of BOA. The membership forms are available on the website www.boamumbai.com. You can download the form and send the documents to the address which is mentioned on the membership form.
I would also like to utilize this break to welcome Dr. Chaya Shinde ma'am. Ma'am is being our inspiration and always the source of this continued medical education for PGs, and she is here today. Very warm welcome, ma'am. Zain is here. Zain, you can start sharing.
Then, while switching between the slides, you can be a little bit slow, especially if there is a video. Then we can't hear you. You're muted probably.
Can you hear me now?
Yeah, we can hear you now.
Okay, sorry for the interruption. Right, so let's get back. So you saw what was the with movement, the against movement and neutralization. Now, it is very important to understand that why the with and against movement takes place. And that can only be explained with the help of the optical ray diagrams that I'm going to show you. And this is something which examiners ask in the exam. That, why do you get a with motion? Why do you get an against motion? And understanding conceptually is very important. So let me try to explain that to you. Okay, so this is the ray diagram in front of you with the principal and optical plane. Okay, we do retinoscopy normally at 67 centimeters, which is one arm's length distance. Okay, normally for a good retinoscopy without any errors, the ideal distance would be to do it at 6 meters, which is the far point of emetropia. But because that is not practical, we do it at a practical distance. So we do it at 67 centimeters, which becomes the far point for a minus 1.5 diopter myopia. So that is why I've written minus 1.5 diopters in the bracket. So because of this, there is an error induced, which I'll talk about later. Anyways, so coming back, let us see now what happens to the rays if this patient has a myopia of more than minus 1.5 diopters. Okay, so the first part of retinoscopy involves illuminating the retina. So you can see with this, the point A of the retina is illuminated with this green ray. And this retina projects back to its far point. So point A1 is the projection from point A, and we know the far point of a myopia of more than minus 1.5 diopters will be somewhere between the observer and the patient, because the far point is the far point will be, the greater the myopia, the closer will be the far point. So this will be point A1. Now, because of this, the pupil reflex will be in the center, as you can see in the top right hand corner. So with a horizontal streak, you will get a central horizontal pupil reflex. Now, on moving the retinoscope downwards, instead of point A, we are illuminating point B of the retina, and this is the paraxial retinal point. And to see how the point B reflects back, we have to follow the two-ray diagram which I had shown you earlier. So point B will project onto B1. And now the point B1 with respect to the retinoscope can be seen with this blue dotted arrow. And since B1 is above the principal plane with respect to the retinoscope, that's why the movement of the pupil reflex will be in the opposite direction. So in a myopia of greater than minus 1.5 diopters, we'll get a against motion. Now, once you have understood this, the others are pretty simple to follow. So again, we'll see a case of myopia less than minus 1.5 diopters. What will happen? Point A of the retina is illuminated, which will project to point A1, which will be behind the observer, since myopia of less than 1.5 diopters will have its far point over there. Then on moving the retinoscope downwards, point B will be illuminated and point B will project onto point B1 again, which is behind the observer. And when we join point B1 to the retinoscope, we see that this blue line is downwards with respect to the principal plane. That's why myopia less than minus 1.5 diopters will have a with motion. Coming to hypermetropia, again the same thing, point A of the retina is illuminated and point A1 will be projected, which is behind the patient's eye because that is the far point. On moving the retinoscope downwards, okay, point B1 will be projected, and if we draw the line from point B1 to the retinoscope, we again see that the movement is downwards with respect to the principal plane. So in hypermetropia, we have again a with motion. And coming to emetropia, point A of the retina projects to point A1, which is at infinity behind the observer. And on moving the retinoscope down, the projected point B1 will again be behind from infinity, and when we draw the blue line, it has a downward motion with respect to the principal plane. So that is why in emetropia we get a with motion. So to summarize all these optical diagrams, okay, before we go ahead, what happens at myopia of equal to minus 1.5 diopters? When the myopia is equal to minus 1.5 diopters, the projected point A1 is directly at the retinoscope. So because of that, the entire pupil will be filled with the reflex. And on moving the retinoscope either in the downward direction or in the upward direction, the speed of the movement will be so fast. In fact, it will be infinitely fast. So whatever direction you move it in, the entire pupil will be filled with the reflex. So as a result of this, myopia of minus 1.5 diopters will have a neutralization reflex, not a with nor a against motion. It will be full of the reflex. So to summarize, myopia greater than minus 1.5 diopters, against motion. Myopia less than 1.5, hypermetropia and emetropia will have a with motion. And myopia of equal to minus 1.5 diopters will be neutralization. This is all if the retinoscopy is being done at 67 centimeters or at a myopia of minus 1.5 diopter. Okay, so this is why the with and against motions take place. And if examiners ask you that why is this, you have to conceptually try to understand these optical diagrams and explain it to the examiner in your own words. But only with these diagrams, you can understand why these movements take place. Okay, so I'll just skip this part. Okay, so now we have understood that why the with and against motions take place. Now we know this, and now how do we proceed? What do we do? So if you have a with motion, as you can see here, you have to add plus lenses. So here in small steps you have to add. So I'm adding plus 0.25 and increasing it. You can see the reflex is becoming sharper, brighter, and you keep doing it until you reach neutralization. And finally, at 2 diopters, I have got neutralization. So the end point of retinoscopy is when you achieve neutralization. So for a with movement, you add plus lenses. In this case, at plus 2 diopters, I've got neutralization. Now, if you get a against motion, okay, so in an against motion, you have to add minus lenses the same way in increasing steps. So here I'm adding -1, and the reflex you see becomes sharper and brighter, and you go on increasing. So now I'm getting closer to neutralization. And finally, in this case, at -3 diopter with a -3 diopter lens, I have achieved neutralization. So that will be my end point in an against motion. So this is how you reach neutralization. And how do we now get the refractive error from retinoscopy? How do we, what do we do? So we know that neutralization is the end point of retinoscopy. That is when we stop. So the power of the lens used to achieve neutralization is noted. So you saw in the example -3 and +2. Now, since we know that the far point of a myopic eye is the reciprocal of its dioptric value, if retinoscopy is being done at 67 centimeters, we know at neutralization, the patient's eye is -1.5 diopters myopic. So basically at neutralization, we are leaving the patient -1.5 diopter myopic. So whatever lens is being used to achieve neutralization, always -1.5 diopters should be subtracted to get the final refractive error. So this is called as the working distance error in retinoscopy. So in this, the examples we saw, a -3 diopter reading in against motion will actually have a refractive error of -4.5 diopter sphere. And because we have -1.5, and if a +2 diopter reading we are getting, the refractive error will be +2 - 1.5, which will be +0.5 diopter sphere. So this is after we have corrected for the working distance. This is the final refractive error of the patient. Okay, so this brings us to two commonly asked questions, which I hope by now you would have understood. Okay, so why do we subtract 1.5 diopter from the retinoscopy reading? The answer is pretty much in front of you. It is because we are at neutralization, leaving the patient myopic by 1.5 diopters and not emetropic. So whatever the working distance error is, that is what has to be subtracted. And someone can ask, what happens if the retinoscopy is done at a different working distance? So if it is done at a different working distance, again, the working distance error will change depending on at what working distance. So if you do it at 1 meter, you have to subtract 1 diopter. If you do it at 2 meters, you have to, if you do it at 50 centimeters, you have to subtract 2 diopters. So this is how retinoscopy is done, and this is how we get the refractive error. Now, before we go ahead, we must understand that we nowadays use cycloplegics in retinoscopy. And what is the purpose of using cycloplegics in retinoscopy? We all know cycloplegic drugs, they cause relaxation of the ciliary muscles. So you can see this upper diagram over here. The lens is in a normal state. And if we give cycloplegia, the lens becomes even flatter than normal. So in a normal state, there is some resting tone of the ciliary muscle. So the lens is slightly curved. So you can see in a normal, with normal inherent ciliary muscle tone, the rays are focused on the retina. But if we give a cycloplegia, if we give cycloplegic drugs, the lens becomes flatter and the rays actually focus behind the retina. So cycloplegia causes the rays to focus behind. It causes the eye to become more hyperopic. What is the need of doing this in retinoscopy? Because many children, they have a very strong inherent ciliary muscle tone, and we want to abolish that while doing retinoscopy. So we do it with cycloplegia. So cycloplegic drugs, what they cause is they cause hypermetropia. If you use a mild cycloplegic like Tropicamide with phenylephrine, it will cause some amount of hypermetropia. And if you do a very cycloplegia with a severe cycloplegic like atropine, it will cause a much higher hypermetropia. So based on this, there is a certain amount of hypermetropia, and this should be understood. There is a hyperopic error produced by different cycloplegic drops. So for atropine, the cycloplegic error is 1 diopter. For homatropine, it is 0.75. For cyclopentolate, it is 0.5 diopters. And for T+, it is again 0.5 diopters. Now this again, there's a variation. A lot of different books give different values, but most examiners accept this as the routine cycloplegic effects. So when we are giving the prescription to the patient, the hyperopic error induced by this cycloplegia has to be accounted for. So that is why this is called as cycloplegic error in retinoscopy, and we have to minus this along with the working distance. So look at the example. If retinoscopy is done with home atropine eye drops at 67 centimeters distance, and the retinoscopy reading is plus 1.25 diopters, then what is the actual refractive error? So the refractive error is 1.25 minus the working distance error, which is 1.5 diopters since it's done at 67 centimeters, minus 0.75 diopters for home atropine. So the actual refractive error in this case is minus 1 diopter. And this sort of retinoscopy with cycloplegia is called as wet retinoscopy. And it goes without saying that if you're doing wet retinoscopy, the subjective refraction has to be done few days after this, because the ciliary muscles need some time to recover from the cycloplegic effect. We can do dry retinoscopy also. At that time, we don't need to do a subtraction for this. Right? So this is what is wet retinoscopy. Okay, so with this understanding, up till now, we have only seen the sphere. We have not seen cylinder. What astigmatism? Let us look at this example. So retinal being done at 67 centimeters with T plus eye drops, and we start with a horizontal streak, and we see we are getting a against motion. So I'll add a minus lens. So just for time, I'm going to start with a high lens, and we see at 3 diopters minus 3, we get neutralization. Okay, so the refractive error here is minus 3 and minus 2, which is minus 5 diopters for the errors. Now what we do is we turn this streak perpendicular. So we make the streak from 180 degrees, we make it 90 degrees, and we recheck if we have still got neutralization with this lens at the 90 degrees also. That means there is no astigmatism. Okay, so this is just a spherical power. But what happens, suppose we get on horizontal streak, there is neutralization, but on turning it vertically, we get a movement, whether it's with movement or against movement. This means that the opposite axis now needs to be corrected further, and this tells us that there is astigmatism, and now this refractive, this retinoscopy needs an astigmatism prescription. So let us, before seeing how astigmatism prescription is given, let us quickly understand the concept of meridian and axis in astigmatism, because again, this is something which is very poorly understood. So look at this toric surface over here. You can see this has a blue color vertical meridian and a green color horizontal meridian. And from the look of it, you can understand that the horizontal meridian is more curved, whereas the vertical meridian is less curved. And if we see it in the 3D model, we can see that the horizontal meridian being more curved focuses at plane A, which is closer, and the vertical meridian, the vertical meridian focuses at plane A, whereas the horizontal meridian focuses at plane B. Now, let us assume we want to correct this toric surface and make both the meridia focus at plane A only. That means we need this horizontal meridian to be corrected to plane A. So for this, we need to add a cylindrical lens. And the cylindrical lens, you can see this yellow lens over here. The cylindrical correcting power of this lens to correct the horizontal meridian will have its axis in the vertical direction. So because it has its axis in the vertical direction, you can see that the axis needed to correct a particular meridian is always opposite to that meridian. So this is something that has to be remembered, that axis of a lens that you put, the trial set, the astigmatism, the cylindrical lenses that you have, the axis that is marked, that is always has to be placed perpendicular to the meridian we are correcting. Okay, so in terms of retinoscopy, how does this translate? The meridian that has to be corrected is always parallel to the direction of the motion, whereas the axis of the lens needed is parallel to the long axis of the streak. So in this upper diagram, you can see that this is a horizontal streak and the movement will be up down. So the meridian we are straddling over here is the vertical meridian, and the axis length that will be needed to correct this will be in the horizontal 180 degrees direction. So similarly, in the lower example, this is a vertical streak, the movement will be horizontal. So we are straddling the horizontal meridian, and the axis of length needed to correct this will be at 90 degrees or vertically. So with this understanding, let us see another example of how astigmatism can be corrected using retinoscopy. So retinoscopy at 67 centimeters with T plus eye drops. So we know the error will be -2 diopters. Okay, so we are getting now a against motion in the for the vertical meridian. We are straddling the vertical meridian. So I'm adding minus lens. So with -2, I've come closer to neutralization. I'll go on increasing it. Okay, now I'm very close at -2.75. At 3 diopters, I've got neutralization. Okay, so my vertical meridian is -3 diopter, -2 for the error. So my vertical meridian is -5 diopters. So I will write this in something called as my retinoscopy cross. So you can see the retinoscopy cross at the vertical meridian. I write -5 diopters because this is my vertical refractive error. Now for the horizontal meridian, I'll turn the streak vertical and I'll start straddling the horizontal meridian. We can see I've got a very thin width motion. Okay, so I'll add plus lenses. So I'm starting with +3 because the motion was very thin. So I'm assuming it to be a large power. And I go on increasing. You can see that I've come closer to neutralization. Again, putting it at 4.75, stronger, brighter width motion. I'm closer to neutralization, go on increasing. At 6 diopters, I have achieved neutralization. Now, at 6 diopters, I have achieved neutralization, and you can see the axis of this cylinder that I have put is 90 degrees because I'm straddling the horizontal meridian. Now, to know what exactly is my horizontal power, what I will do is I will calculate this cylinder which is in place and add it to whatever is already there. So I know that there is already a 3 diopter sphere there. So I will add my +6, which is what I've got for the horizontal meridian, to -5, which is -3 with the working distributed sphere. So I've got +6 plus -5. So my horizontal meridian is +1 diopter, and I will write the +1 diopter on the horizontal meridian of my retinoscopy cross. And this is how you write the retinoscopy cross. This is how you deduce the retinoscopy cross from your retinoscopy reading. Okay, so now the next and final step of refraction of retinoscopy is to convert this retinoscopy cross into your objective refraction correction, which is your prescription pattern, which I've shown earlier. So now whenever I have a minus and a plus on the two axes, this is a case of mixed astigmatism. See, I have purposely shown you a difficult case of a mixed astigmatism because of the lack of time. But if you just follow the rules, everything is pretty straightforward. So there are rules to convert this mixed astigmatism cross into the prescription. So for mixed astigmatism, whenever you have opposite signs, these are the steps that you have to do to convert it into a prescription. Okay, so the step 1 is any of these two values you can take to be the sphere. So I can take -5 or +1. So in this case, I take -5 to be the sphere and I write it down as -5 diopter sphere. Now for the cylinder, I take the sign opposite to what was the sphere. So the sphere had a minus sign. So cylinder sign will be plus. This is for mixed astigmatism. The third step is the numerical values of the cylinder and sphere have to be added. Remember, numerical values, that is 5 plus 1, 6 without the signs. So the value for the cylinder will be 6, and we've seen that the sign for the cylinder was already plus, that is in step 2. So you're combining step 2 and 3, the cylinder value is +6 diopter cylinder. And lastly, for the axis of the cylinder will be that taken of the sphere, because we know that the meridian and axis are opposite. So if we are correcting the horizontal meridian with a cylinder, we have to give the axis of the vertical axis. So because of that, we give the axis of the sphere, which was taken in step 1, which was 90 degrees. That is the axis of the cylinder. So the final refraction is -5 diopter sphere with a +6 diopter cylinder at 90 degrees. And this is how you go about converting a mixed astigmatism retinoscopy cross into a final prescription. Okay, when both meridia have the same sign, this is not a mixed astigmatism. This becomes a compound astigmatism. So when there's a minus sign, this is a compound myopic astigmatism. Let us see how we go about doing myopic astigmatism, how to convert it into the prescription. It's different from mixed astigmatism. So in this case, the sign for both the sphere and cylinder will be the same. Okay, that is a minus sign. So we take the smaller numerical value to be the sphere. So the smaller numerical value here is 1.5. So this is minus 1.5 diopter sphere. The cylinder will be the difference between the numerical values for both the meridia. We saw in mixed astigmatism, we had to add up both the values. For a compound astigmatism in which the signs are the same, we take the difference between the numerical values for the cylinder. So 5 minus 1.5 is 3.5 diopter cylinder. The sign of the cylinder will be minus only because this is a myopic astigmatism. And again, the axis of the sphere, the axis of the cylinder will be taken of the sphere. So the sphere we are taken as minus 1.5. So the axis will be 180 degrees, that is of the sphere. So the final prescription becomes minus 1.5 diopter sphere with a minus 3.5 diopter cylinder at 180 degrees. For a compound hyperopic astigmatism, again we do the same thing, except that everything is plus. So the sign for both sphere and cylinder will be plus. The smaller numerical value will be the sphere, 1.25. The cylinder will be the difference between the two numerical values, again 1.25. The sign of the cylinder is plus, and the axis is that which was taken of the sphere originally. So this is the final prescription for this hyperopic astigmatism is plus 1.5 diopter sphere with plus 1.5 diopter cylinder at 90 degrees. And this is how we convert retinoscopy cross into the final prescription for mixed compound myopic and compound hyperopic astigmatism. So in your exam, when you get a retinoscopy case, you have to write this cross, and from that you have to write the prescription. Okay, so that is why I showed it to you this way. But when you do retinoscopy practically, you don't need to make a cross. You can just directly write the prescription. I'll just show you how. The same case we are taking. Okay, so the same case where there was a neutralization of the vertical meridian with minus 3 diopter sphere. So that was minus 5 diopter sphere directly you can write over here. And for the cylinder, we had neutralized it with a plus 6 diopter cylinder at 90 degrees. The axis was 90 degrees. So when you're doing practically, you can directly just write this as, you can directly write it as minus 5 diopter sphere with a plus 6 diopter cylinder at 90 degrees, and you don't need to make a cross or anything like that. Okay, so practically this is how we do it. We just write the axis of the cylinder, what power of the cylinder we have taken and what is the axis, and this is how it can be done practically. So this was all about retinoscopy in brief. There are a few topics which I haven't covered still. Those topics you can find in the textbook. So retinoscopy, what we have answered, we have understood what is the optical principle of retinoscopy. We have understood why with and against motions happen in retinoscopy. We have understood the concept of working distance error, cycloplegic error. Why do we subtract 1.5? What happens if we change the retinoscopy working distance, and why? How is the final refractive error calculated, and how to infer the spectacle prescription from the retinoscopy cross for myopic, hyperopic, and mixed astigmatism. So that completes objective refraction. And I have the second presentation on subjective refraction. Should I go ahead to that? It will take about 20 minutes. Or do we answer questions and do that later? Dr. Swapnesh and Dr. Sumit?
I think subjective you can complete. We have 2 or 3 questions which we'll answer at the end.
Okay. Right. So subjective refraction is not as conceptually heavy, as objective refraction. It's much more fun. It's much easier, and it's not that difficult to understand. Okay, so we have now got the objective refraction, and in subjective we use the patient's assistance to refine this objective prescription. Okay, so we have the patient sitting comfortably in our OPD, and we give the trial frame to the patient, and we make the patient look at a Snellen's acuity chart at 6 meter distance. We have our trial set ready to put in the lenses, and we have a prescription ready, which we have inferred from objective refraction. So here is an example I've given. This is for the right eye, the example is minus 1 diopter sphere with minus 0.5 diopter cylinder at 90 degrees. So how do we now go ahead with the subjective refraction? First things first, this is a right eye prescription. So we occlude the left eye and we put in our prescription. So -1 diopter sphere is put into the trial frame with a -0.5 diopter cylinder at 90 degrees. And now we go ahead refining this. So what are the steps to refine this? The first sphere check, the cylinder check, the axis and magnitude, the second sphere check, or rather the sphere confirmation, then binocular balancing, and finally, if needed, presbyopic or reading addition. So let us go into these steps. So the first sphere check, we know that the sphere put here is -1 diopter. How do we go about checking it? Very simple. We just check what is the best corrected visual acuity with this prescription, and then we move the sphere in a range of ±1 diopter and see if the visual acuity improves in a particular direction. So in this case, for example, let's say the visual acuity is 6/12 in the right eye with this prescription. So I'll remove this -1 diopter sphere and put in a -0.5 diopter, and I ask the patient if it's better. And yes, it is better. The visual acuity has improved to 6/9. I'll go ahead further. I'll remove the -0.5 and leave the patient without a sphere, and I'll ask if now it is still better. But the patient says, no, it's worse than before. Still the visual acuity was 6/9. So I know I've gone too far. So I'll put back the -0.5 diopter sphere, and this completes my first sphere check. This is just a rough estimation of whether the sphere is accurate or no. After the first sphere check, my prescription is -0.5 diopter sphere with -0.5 diopter cylinder at 90 degrees, and the visual acuity is 6/9. Now, the second step is the more important one in subjective refraction, which is checking the magnitude and axis of the cylinder. And there are multiple ways to do this, but the way which is most important and most sensitive rather is the Jackson's cross cylinder, the JCC, what we all call as. So I'll be discussing this Jackson's cross cylinder and not the other methods, because this is very commonly asked in the exam. And the students, the postgraduate students need to know how to use this. Even today in retinoscopy, in refraction, this is used very commonly. So what is the Jackson's cross cylinder? So you can see this is nothing but a lens which is mounted on a handle. So this lens is a peculiar lens. It's a spherocylindrical lens with opposite powers in the opposite meridian. So in one meridian, you have minus power and an exactly opposite plus power in the opposite meridian. So you can have either minus plus 0.25 or minus plus 0.5, or even 0.75 or 1 are used, but these are the most commonly used one, 0.25 and 0.5. And the minus sign is shown in red and the plus is usually shown in green or in black. So you can see over here that this is the refractive power, a plus 0.5 and a minus 0.5. What is this? This is nothing but a mixed astigmatism prescription. So if you write down the prescription of this JCC, you get a value like this. I've already shown you how to get the prescription from a mixed astigmatism. So now let's go and understand how we use the JCC to refine the cylinder. So first step is to refine the cylinder axis. Okay. So what we do is, for axis, generally we prefer using a 0.5 diopter Jackson cross cylinder. Now for axis refinement, the Jackson cross cylinder is held in front of the trial frame with its handle being parallel to the axis of the cylinder. That means your red and green marks should be 45 degrees away from the axis of the cylinder. And this is position 1. You ask the patient to see the Snellen's acuity chart. Then you just flip the JCC so that the red and green marks, they reverse their orientation. This becomes position 2. And you ask the patient, is the visual acuity different between position 1 and 2? If there is no gross difference, that means the axis of the cylinder is correct. If there is some difference between the two, that means the axis of the cylinder needs to be refined. And let us see how we go about refining the axis of the cylinder with JCC. Okay, so we place the JCC with its handle in direction of the. Okay, so we place the handle at 90 degrees. So and the plus part is at 135 degrees. Now this is position 1. We ask the patient to look at the Snellen's chart, and now we flip this JCC. Okay, on flipping the JCC in the opposite direction, the minus has come at 135 and the plus has come at 45, and this is position 2. Now we ask the patient, which is better, position 1 or position 2? In our example, suppose the patient says position 1 is better. Position 1 is better. That means that position 1 was where the minus was at 45 degrees and we have a minus cylinder. That means we have to move this minus cylinder closer to 45 degrees and we do that in small steps. Okay, so we move this cylinder prescription from 90 degrees to 85 degrees, and we redo the thing. Now we redo the Jackson's cross cylinder, position 1 and position 2. And we ask the patient which is better, position 1 or position 2. Again, the patient is saying position 1 is better. That means we have to further refine it. We move the cylinder to 80 degrees now. And we redo the JCC, position 1 and position 2. And now we ask the patient which one is better, 1 or 2. And the patient says now both are equal. That means the axis, the corrected axis, instead of 90 degrees is actually 80 degrees. And this is how we go about refining the axis of the JCC. Now, this is basically continued for some time. It's not always that the patient says that, I am seeing both equal. The equalness continues for few more positions. And then finally it reverses where patient says the other position is better. But just for an example here, I've shown you, ideally what you're supposed to do is you're supposed to continue doing it until the patient gets a reversal. And then you have to again go back and see which axis is the best where it is equal. So this was how you refine the axis of the cylinder with JCC. Next comes to refine the power of the cylinder with JCC. Now for power, we generally prefer a 0.25 diopter JCC, but if you have a 0.5, you can go ahead with that also. For axis refinement, the JCC has to be held with the minus and the plus sign, they being in the direction of the cylinder and not being oblique to it. Okay. So the JCC has to be held with the axis in the direction of the cylinder, and this is position 1. Then again, you do the same thing, you flip it, and then it's position 2, and you ask the patient if there's any difference. If there's no difference, there is no power, the power of the cylinder is correct, and you can stop. If there is some difference, then you need to refine it further. Let us see in our example. So now in our example, we have our minus 0.5 diopters at 80 degrees, and we'll place the JCC with its axis in the direction of the cylinder. So now we place this with the minus at 80 degrees and the plus at 170 degrees. This is position 1, and we switch over to position 2. And we ask the patient which one is better, position 1 or 2. Patient says position 1 is better. Position 1 was when the minus was in the direction of the cylinder, and this is a minus cylinder. So this tells us that we need to increase the minus power. If the plus would have been a better position, then we would have to decrease the power. So here the patient says that with the minus in the axis of the cylinder, the view is better. So we need to increase. So from minus 0.5, we change it and make it minus 1 diopter. And now we repeat the test. So with minus 1 diopter in place, we put the JCC in front. Again, this is position 1 and this is position 2. And we ask the patient which one is better. Now patient says both are equal. That means now we have refined our cylinder power, and the corrected cylinder power is minus 1 diopter. So the original prescription was minus 0.5 diopter sphere with minus 0.5 diopter cylinder at 90 degrees. Visual acuity was 6/9. After the cylinder correction with JCC, we've got minus 0.25 diopter sphere and minus 1 diopter cylinder at 80 degrees. And the visual acuity for this is 6/6. Now, something you must have noticed, that my sphere power has become minus 0.25 from minus 0.5. So when did we change that? One thing you have to remember about JCC is that if you change the cylinder power by a certain value, you have to change the sphere power by a half value in the opposite direction, so that the center of least confusion stays on the retina. Okay, this may be difficult to understand, but just remember that this has to be done. So we increase the cylinder power from minus 0.5 to minus 1. So we change it by 0.5. So the cylinder reduced, the sphere reduced by half the value, that is by 0.25. So the sphere became minus 0.25 and the cylinder became minus 1 at 80. And this is how we do the second part of subjective, that is cylinder check. After this, we have to reconfirm the sphere. Okay, what is the purpose of reconfirming the sphere again? The purpose of doing this is to make sure that the patient is not accommodating at all. And to ensure that the patient is not accommodating at all, we do certain tests. I'll just come to that. But how to, why is this accommodation so important? If you look at this figure over here, this is a hyperopic patient focusing behind the retina. If we add a +1 diopter lens with accommodation being at rest, the rays are still focusing behind the retina, means the patient is still slightly hyperopic. But if the patient accommodates little bit with the +1 diopter lens, he will be able to see clearly. The rays will focus on the retina. So with +1, the patient is able to see clearly, but this is not the actual power because the patient is accommodating. And a 1.5 diopters will cause the patient to focus on the retina with accommodation being at rest. So that means that the actual refraction of the patient is not +1, but actually +1.5 diopters. And because of this, we in hyperopes, we have to always overcorrect the prescription to make sure the patient is not accommodating. Myopia is exactly the same. You see in this case of myopia with a -1.5 diopters, with accommodation, the patient is focusing, but without accommodation, the patient is actually focusing behind, means this patient is overcorrected. And the actual value, the myopic value for this patient is -1 diopter. So in myopes, we have to always undercorrect to make sure that the patient is not accommodating. So how do we make sure that the patient is not accommodating? We do that with this second sphere check. And there are two ways. For hyperopes, it is done separately. For myopes, it's done separately. For hyperopes, the method of making sure the patient doesn't accommodate, this is called as the fogging method. In fogging, we put much higher power spherical positive lenses, and we do that until the visual acuity becomes bad, and then we rapidly remove those lenses until the visual acuity again improves back to normal. So let me show you with an example. This is a +1.25 diopter sphere, and we want to make sure this patient is not accommodating. So we do fogging. For fogging, we add high power plus lenses. So I've added +3 diopters sphere, and I rapidly reduce in either 0.25 or 0.5 steps until the visual acuity comes back to the 6/6 which the patient originally had. And in this example, say at 1.5 diopters, the patient is reading 6/6. So that means the prescription has to be changed from 1.25 to 1.5 diopters. And this is how fogging is done. For myopia, we do a test called as the DUOCHROME test to make sure that the patient doesn't accommodate. Quickly, let me explain to you what is the DUOCHROME test. The DUOCHROME test is based on chromatic aberrations of the eye. So chromatic aberration means that when white light enters the eye, it splits into its individual colors and they focus at different parts based on their wavelength. So we know red light has a longer wavelength, so it focuses slightly behind the retina, whereas yellow light having a moderate wavelength focuses on the retina, and blue light focuses, blue and green focus in front of the retina. So in a normal emetropic patient, the red light will focus slightly behind and green light will focus slightly in front. So in duochrome test, we ask the patient to read letters against a red and a green background. And if the patient is emetropic, he will see the red and green letters equally because the green light and red light are equidistantly focused from the retina. Now let us see in case of a myopia how we use the duochrome test to correct the sphere. So this example you can see -0.5 diopter sphere with -1 diopter cylinder 80. We just at this, the patient is reading 6/6. We just want to know if this sphere is okay, means is this -0.5 overcorrected, undercorrected, or adequately corrected. We know myopia, we have to not overcorrect. So we do the duochrome test and we ask the patient to look at the red and green letters and whether they can, whether they both appear equally bright. So in this example, we can see both the colored letters appear equally bright. So this is an adequate correction. With the -0.5 diopter sphere, the green is focusing equally in front and the red is focusing equally behind. So this is an adequately corrected myopia and we don't need to do anything further. What about this example over here? You can see that the green is focusing, is looking much brighter and the red is looking slightly dull. So what does this mean? This means that with the -0.5 diopter sphere, the green is actually focusing on the retina and yellow is focusing behind and the red is focusing even more behind. The yellow is focusing behind. That means this myopia is overcorrected and we have to reduce this overcorrection. So what we do is from 0.5, we change it to -0.25. And when we change it to -0.25 now, the yellow is focusing on the retina. So that means now we have adequately corrected the myopia. So we have to always make sure that the letters look equal and not green should never be brighter than the red. In this last example, we can see that the red is brighter than the green. This means that the myopia is slightly undercorrected. That means the red is focusing on the retina and the yellow is focusing in front. That means the patient is undercorrected. So what we can leave the patient as it is, or we can give a trial of a higher power lens of minus 0.75 diopters and make sure that the patient reads both equally. But in practice, we can always leave the patient slightly undercorrected for myopia, because that will ensure that the patient is not accommodating at all. And this is how you go about doing the duochrome test. After we have confirmed the sphere in one eye, then we give the prescription to the patient in both the eyes, and we make sure that the patient is seeing well with both the eyes, and we check that the patient is comfortable. Especially this binocular balancing is important in anisometropia, when the refractive errors are very different. There can be a difference in magnification. Like if one eye is -2, the other eye is -8 or 9, that can cause difference in magnification that is called anisoconia. This can result in diplopia. So we just have to reduce the power a little bit. But that is only for extreme, odd cases where one eye refractive error is higher. Otherwise, most of the times the patients are comfortable. So this was the fourth step, binocular balancing. And the last and final step for subjective correction is doing the near vision correction for patients above the age of 40 years. So presbyopia correction is again an art which cannot be discussed in this lecture because it's a topic by itself. But we generally have guidelines for different age groups, the power of the spectacle that needs to be given, the reading ad, what we call. But we have to always make sure we individualize for each patient based on their working distance. Some people like to read close, some people like to read far. So based on that, we have to give a proper prescription for reading. And with this, we complete our subjective refraction. The last thing is to give the final prescription to the patient so that the optician can understand. So this is a format, how the prescription should be written in an ideal sense. You should have right eye, left eye, sphere, cylinder, axis, visual acuity. The near total is always written above the near ad because the near total includes the cylinder and axis. So we have a common box for cylinder and axis for the near total, and the near ad is mentioned below. So the optician knows what is the addition given for reading, and they also know that including the sphere, what is the total power for near. So this is how the prescription has to be given. And even in the exam, when you get a retinoscopy case, this is the final step. This is how you write the prescription for the exam. And with that, I complete my presentation. I thank BOA for this opportunity, and I have my YouTube channel where I have explained some of these retinoscopy videos in case you want to go through it again. Also on the YOC website, I have my retinoscopy video. Thank you.
Thank you, Zain. That was really refreshing and like to the basic presentation, which is very important for all the PGs. So there are 2-3 questions that we need to take up here. Very first is why or how our eye is -1.5 diopter myopic at 67 centimeter?
So see, basically any optical lens, if it has a converging power, there's a formula. There's a formula for the vergence power of an optical lens. So suppose you consider a patient's myopic eye to be the lens. Like for example, if the patient's eye is say 1.5 diopters, the formula for the convergence formula for any lens is always the reciprocal of the place where it focuses. So suppose it focuses at a 1 meter distance, for example. So the power of that lens is 1 diopter. So if it focuses at 50 centimeters, the power is 2 diopters. So similarly, in our eyes, it is the opposite. If the patient has a myopia of 2 diopters, its far point becomes 50 centimeters. This is a formula, and it is based on the vergence formula of any optical lens.
Okay. And there is one more question. How to find out a mean spherical equivalent, and does it hold any importance or the place in subjective refraction?
So of course, it is important to know the spherical equivalent. So spherical equivalent doesn't hold, I'll just explain how the spherical equivalent can be calculated. But before that, the importance of the spherical equivalent, not so much for spectacle prescriptions because we are giving the sphere and cylinder to the patient, but it can be of use when we are prescribing contact lenses, because many of the toric contact lenses, patients don't use toric contact lenses, and if you want them to be comfortable, if the cylinder is small, say a 1 diopter cylinder or a 1.5 diopter cylinder, say a prescription is -2.5 diopter sphere with a -1 diopter cylinder, and this patient wants a contact lens. So you can give a non-toric contact lens calculating the spherical equivalent, where the patient's circle of least diffusion will be focused on the retina. So how to calculate the spherical equivalent? It is calculated by taking half of the sphere value and adding it algebraically to the, taking half the cylindrical value and adding it algebraically to the sphere value. So for example, if a prescription is minus 2.5 diopter sphere with a minus 1 diopter cylinder, you want to find out the spherical equivalent. So the half of minus 1 is minus 0.5. So you add minus 0.5 to minus 2.5. So the spherical equivalent for this patient will be minus 3 diopters. So that is how it is done.
Okay. Then there is one more thing. It's a fogging with the +1 diopter lens needed before refining a axis with the Jackson cross cylinder.
Yes, some people do recommend doing that. See, Jackson cross cylinder basically has a lot more details than what I have explained. It's a topic by itself. But yes, what does fogging do before putting in a Jackson's cross cylinder is it blurs the image. If you have a very clear image in the beginning only, what will happen is the patient may not be able to identify the difference between position 1 and 2. So what fogging does is it relaxes the accommodation and also blurs the image slightly. So if say before putting the 1 diopter lens, the patient was reading 6 by 6. If you fog the patient with a 1 or 1.5 diopters, the vision will now become 6 by 12. So now the vision is blurred. Now you can use the Jackson's cross cylinder to show the positions and see which one is more clear between the two. So yes, actually fogging with a +1 diopter can be done to reduce the visual acuity.
Okay. And one more last question. What are the methods to cross-check the endpoint of the retinoscopy or your neutralization point?
Basically, the methods I've already discussed. You just have to, be good with being able to identify the movements. So what happens is that, this only comes with practice. You have to do your retinoscopy and you have to be able to identify that, okay, now from a against motion, I've got neutralization. What you can do is one step ahead of neutralization, you add one more lens and you see if the movement has reversed. Suppose the movement has changed from a with motion to an against motion, you know that the previous power was your neutralization and you stop at that. Sometimes you may also feel that you're getting neutralization at 2-3 powers, at +0.5, at +0.75, at 1. You're getting neutralization at all three. So you take the middle power neutralization as your neutralization value. See, objective retinoscopy has to be refined after subjective refraction. So it will always be only a rough value. Little bit up and down is okay, as long as you do a good subjective refraction after that.
Okay. Okay, fine. I think that finishes all the questions.
There's one more question which has come up. Could you elaborate on what are the sleep positions of a streak retinoscope?
Okay, so again, I hadn't discussed streak retinoscope over here. That has to be read, but just quickly let me explain to you what is the purpose of the positions. So now, before we had the self-illuminated retinoscopes, we had the mirror retinoscopes. Okay, so we had a plane mirror retinoscope and we had a concave mirror retinoscope. So the plane mirror retinoscope was basically meant for normal refractive errors of +1, 2, 3. And sometimes when the patient's refractive error was very high, like say -8, -9, the reflex would be so dull with a plane mirror retinoscope that we wouldn't be able to understand whether it's moving with, it's moving against. So for that purpose, there was a concave mirror retinoscope, which would change the optics. Now, how the optics change, again, you have to go to your textbooks and read because I can't explain that to you right now. But the optics would change such that a higher refractive error you would be able to see the movements clearly and you'd be able to understand whether it's a with motion or a against motion. So what the sleeve of the streak retinoscope does is it adapts to the concave mirror and the plane mirror retinoscope. So when you keep the sleeve lowermost, that is when you're talking about the plane mirror. It's like a plane mirror retinoscope. And when you take the sleeve on top, it becomes like a concave mirror retinoscope. And only for higher refractive errors, you need to use that. Otherwise, for normal basic refraction, you have to keep the sleeve lowermost.
Great.
So
I think very, very well covered by Zain. And only one major point which Zain has not discussed at all is don't do subjective retinoscopy of a patient of whose objective retinoscopy has been done by your fellow resident. So you do the objective retinoscopy and see the same patient next day, and you do your own subjective retinoscopy, this will improve your skill of retinoscopy. This is what we used to follow during our residency. That don't do subjective retinoscopy of your fellow colleague, because he may have done it wrongly, or he may have done it in haste, and you would be stuck up with a retinoscopy reading, a retinoscopy crossbar written on the OPD sheet. You would be struggling to give a good refraction to this patient. So always make it a point that you do one patient objective and the same patient, wherever you are in the OPD, come back and do a subjective retinoscopy of the patient whom you have done the objective retinoscopy in your previous OPD. So that's a rule which we follow. Am I right, Sumit?
Yes, sir. Totally correct. It precludes your mind with the already written readings and you try to get the same. Many times it doesn't happen.
So thank you, Zain, and it was a wonderful presentation. I'm sure you will get a lot of YouTube hits on our channel also. And thank you for accepting the invitation. Thank you, Sumit, for coordinating all this. Just announce next topic and the time. And
so this time we will be having lecture every Tuesday and Thursday. That is between 7 to 8 p.m. And our next lecture again, starting with the basic, as the new batch of PGs has been joined everywhere. That is basic slit lamp eye microscopy, parts and the uses of the slit lamp. So that will be on the Thursday by Dr. Ganesh at between 7 to 8 on a day after tomorrow. So till then, keep reading, and you know the topic, so you can read a bit all beforehand, and then you can ask the questions if any doubt arises after attending the lecture. Thank you, Zain. Thank you, Sapne sir, and thank you everyone for attending.
Thank you, Zain.
Thank you. Bye.
Bye, Sumit.